So VQ mismatch. So again, normal. We have normal high VQs and low VQs. We kind of mentioned this already in passing, right? Our lungs have a lot more blood in it. Where the bases or the apices? At the bases, there's a lot more blood because of gravity, and that's actually our ideal place for what kind of catheters? These little PA catheters, and we'll talk about this in hemodynamics, right, in cardiac. But that's the ideal placement because we don't have interruption of all these airway pressures that might be influencing our hemodynamics. We want a pure evaluation of our cardiac numbers, right? Areas of high VQ, right? That's going to be where? At the top of the lungs or base of the lungs, or high VQ? Yeah, top of the lungs. They got a lot of ventilation, right, compared to blood, right? And yeah, hyperoxic blood. So there's a lot of oxygen will return to the heart compared to low down here, but it all kind of evens out to an average oxygen concentration in the lungs, and in the bloodstream, right? And if we're measuring the oxygen in the bloodstream itself, what's that called? ABG will give us this number, which is which number? Yeah, good, the PaO2, right? So all this oxygen that we pick up in the lungs, we can measure in the bloodstream, right? We can measure the PaO2, right? On the other side is the PVO2, the partial pressure of venous oxygen versus the partial pressure of arterial oxygen, right? And we can measure either one. Okay, and low VQ, that's where we have more perfusion compared to oxygenation. And again, hypoxic blood is going to return to the lungs. Zone 3 is where this, if you label them 1, 2, 3, right? That's where we have a lot more blood, a lot more Q compared to air, right? So again, here's a normal lung right here, right? So we're exchanging oxygen and CO2, right? Oxygen's going in, CO2 is going out, right? Everything's fine. But then over here, we have a complete shunt, right? Why do we have a shunt? Is that because of a PE or because of a pneumothorax? So there's two extremes. There's dead space and there's shunts, right? Dead space is where the air goes in and just exits, right? A shunt is where it just goes from right side to left side, right? So why would that happen? Pneumothorax or PE, which one? Pneumothorax, right? So they have a collapsed lung. That alveolus over there is not getting any kind of air supply at all. So that'd be a low VQ or a high VQ mismatch. So high VQ only happens when you have a drop in perfusion, right? That'd be like a PE. This is a low VQ. Remember I told you 9.5 times out of 10. If you're going to Vegas, you're just saying low VQ every single time, right? That's going to get you a lot of right answers, right? And then over here we have an alveolus that looks kind of normal, but that doesn't look normal, right? This might be from someone who has like congestive heart failure, right? They got CHF over here, and their left atrium is dilating because the left ventricle failed or it's failing, right? They got an EF at 10%, fluids backing up, and it's causing what? Pulmonary what? Pulmonary edema, right? So that pulmonary edema, all those vessels getting dilated, and then it's going to be increasing what's called hydrostatic pressure. It's going to get, these vessels get so swole that they can't get swollen anymore, and the fluid's going to start filling up these lungs, right? And that's called cardiogenic pulmonary edema. The only reason I specify that because there's such thing as non-cardiogenic pulmonary edema, right? So cardiogenic pulmonary edema is where all the fluid's backing up into the lungs, right? And that's going to reduce my VQ or increase my VQ. Yeah, it's a low VQ, right? So I have perfusion's fine, right? I'm delivering blood to the lungs excellently, even more, right? So I went to the left heart, I came back and said, here's some more blood, right? But does that help anybody? Not really, right? Because that fluid's going to start filling up, and it's going to start causing issues. It's going to come in here. It's like, oh, I can't deliver oxygen here. Go right back out. That's a dead space, right? So that's a VQ mismatch because of CHF, because of pulmonary edema, right? And that little, stuff inside the alveolus can be different things. It can be pus, right? And that's called a what? When there's pus inside the alveolus. Yeah, infiltrates or pneumonia, right? So that's what we're looking at when we talk about, these different blockages of the lungs or blockages of the vasculature. Yes?
So then would a non-cardiogenic be like ascites?
No, because so non-cardiogenic pulmonary edema is ARDS. That's the definition of ARDS. So acute respiratory distress syndrome or ARDS is where you have all kinds of fluid building up in the lungs, but it wasn't the heart's fault. That's basically the definition, right? So I think on the next slide we have a picture of it. All right. So this guy here. So VQ mismatch, right? So our different mismatches, our different pathologies that can happen. We've been talking about them the whole way through. There's a little summary slide of all of our little VQ mismatches, right? So it could be due to several different things. It could be due to a lung process. It could be due to a delivery process, right? Where you're not delivering enough volume or enough blood flow to the lungs. So that'd be like a PE, right? Or not delivering blood flow to the lungs itself, right? But most commonly, it's because we have, there's atelectasis or there's edema or pneumonia in the way, right? We have a low VQ and we can't oxygenate our blood because there's something in the way, right? There's, atelectasis again. There's pulmonary edema or non-cardiogenic pulmonary edema, okay? So failure to oxygenate can be, that's what we would kind of talk about the whole time, right? Failure to diffuse oxygen, CO2 across all this stuff that might be in the way, okay? And then diffusion abnormality, where we have a fibrosis of the lungs, right? There's the alveolus are extra thick, right, with two C's. They're extra thick alveoli, and you can't get the O2, CO2 across easily compared to a normal alveolus, right? So over here, for instance, we got diffusion abnormality. You got all this stuff which is scar tissue and fibrosis, right? Collagen, that's like the scleroderma, for instance. Lupus has this problem, okay? They have a diffusion abnormality, pulmonary fibrosis, interstitial lung disease, mesothelioma exposure, right? Long COVID, all these things are a diffusion abnormality. So they are chronically hypoxic, right? Because of that. We talk about normal VQ, usually it's about 0.8 technically, right? And then what else is another reason why we might not get oxygen to our lungs? It's not a failure to oxygenate, it's really a failure to get the oxygen to the alveolus in the first place. And this is where we can introduce CNS disorders, right? You have a CNS problem, or you have an abdomen problem like you mentioned. You have ascites. It's a really big ascites, a really big obesity. It makes it difficult to breathe. You just can't breathe. You can't breathe because of something physical, right? That'd be like ascites or obesity and such, right? Or there could be like blood filling up or something to that effect. But the other reason why you can't physically breathe, or you can't breathe, or can't ventilate, can't move your diaphragm down and up, right? You can't move your diaphragm down not because of ascites, but because of something CNS related or peripheral nervous system related, PNS, right? So you have a CNS problem or a PNS problem. PNS said slowly, right? Because it's not a penis problem, it's a PNS, parasympathetic nervous system problem. Okay, so we have a problem of delivering that nerve signal to our diaphragm in the first place, and we can't bring our diaphragm down to actually ventilate. Something muscular happening, right, with our diaphragm. And we have other muscles that can help with breathing, such as what? You got your intercostals, you got your sternocleidomastoids, you got your scalene muscles. All these things can help. But if you have, for instance, you have myasthenia gravis, which is really the hot topic in this hallway over here the last 3 days. But you have myasthenia gravis, that's a destruction of the neuromuscular junction at the diaphragm itself. So right down here, everywhere. It's not just one specific spot. It's everywhere. All my muscles they can't operate, right? And obviously I can't ventilate. So is my VQ high or low? It's low, right? You're just guessing, right, at this point, right? So no, I'm kidding. So you have a low V, right? The V is low because I can't ventilate physically, right? Or I should not say physically, I use physically as abdomen problems, but you can't ventilate because of something neurological, okay? And then it could be airway issues, right? That's physical as well. We got our airways clamped off, right? We got a bronchospasm of some sort. We got epiglottitis in kids. All these things are making it so I can't get air into the lungs because of a physical obstruction. And then narcotics is something we give commonly in the hospital, and that can make our ventilation reduce. It's not a problem with oxygenation. Our lungs operate just fine. It's just my lungs have stopped breathing because I've slowed it down. Okay, Guillain-Barré or a nerve injury, right? Which nerves keep your diaphragm alive? The ones from C345, right? So C345 keep my diaphragm alive. Those are, if I have neck injuries, and I'm worried about diaphragmatic problems, right? Our phrenic nerves. Okay, so that's the failure to ventilate versus failure to oxygenate. Those are problems that can happen. Okay, all right. So real quick, let's take a quick break. But before the break, I want you to answer these questions. I want you to answer what is the VQ mismatch, like what disease is this? So we got like 1, 2, 3, and I think 4 is next, 5 is next, and 6. So we've got 6 problems here. And I want you to describe what disease you're looking at and what VQ mismatch you're looking at? Is it low or high, right? Is it shunt or dead space? All right, so you answer those 3 questions. That makes sense? Number 1, top left over here, what do you got?
Low VQ.
You got a low VQ, but what disease is this? Well, if there's 6 questions and I told you 9.5 times out of 10 is low VQ, that's probably going to be the answer for each one of these except for 1. So yeah, so low VQ, right? But what disease process is that?
Like asthma.
Not really asthma. Asthma does sometimes have mucus, but asthma is more of an upper airway disease where you have, and it's more of a restrictive airway disease where your bronchioles are restricted or bronchoconstricted, right? And also you get fibrosis and other things. You do get mucus production too, but you could argue it, but let's just make this a little more mucousy, okay? So you got a lot of mucus there. That's called and that kind of sits down there. That's called a what? That's called a pneumonia, right? So you got pneumonia of some sort. And yes, there's viral pneumonias, bacterial pneumonias, there's interstitial pneumonias. There's all kinds of different things that can cause pneumonia, different bacteria and such. And adults versus peds versus elderly had different bacteria that cause it. But ultimately, it's an inflammatory response. And when you have inflammation, you make pus, right? That's the death. That's white blood cells that have kamikaze themselves against bacteria, okay? So yeah, so we have a low VQ, right? And that's called a shunt, right? So we're shunting, so the blood arrives like, oh, and then it goes right back to the other side of the heart, right? Because there's mucus in that way of that alveolus. Okay. What about number 2 at the bottom left there? What's that? That's a PE, right? So we can see the PE right here, right? So we had a PE that's traveled from maybe a DVT down in the extremities. It could be like endocarditis. They could have had emboli brewing there. They could have a huge dilated heart with a really bad CHF, or with a post-MI, they can have ventricular rupture. They can have all kinds of things, or ventricular thrombus actually, that would cause a thrombus to develop, and the thrombus has now moved. It's a clot in motion, and it moved to the where? To the pulmonary arteries, right? So it's called a pulmonary embolism. So is that a low VQ or a high VQ? It's a high VQ, right? The V is great, right? There's plenty of ventilation, but the Q has plummeted, right? It's no longer 10, it's gone all the way down to, let's say, 1, right? Because you can't divide by 0, right? If I have 8 students in the room right now and I divide it 0 times, well, yeah, maybe, but that blows your brain, all right? All right, so we got this guy right here, all right? So we have a high VQ in this situation, okay? The ventilation is great, but the Q is plummeted, so that's a bigger number than 0.8. All right, number 3, what is that? So yeah, it's a low VQ. And good. So we got fibrotic changes there. We got fibrosis. That's gone around the alveolus, right? So the artery here can't pick up any kind of blood, right? Or very, very reduced, right? So the O2, CO2 exchange is not great, right? So they're chronically hypoxic. Okay, and usually fibrosis does not just happen in one side of the lungs, right? It's usually pronounced through all the lungs. Okay, so then number 4. So here's number 3, right? So we have a low VQ, that's called a shunt, right? And we have pulmonary fibrosis. So what's the next one, number 4? Bottom middle. So we have a pneumothorax that's happened. The lung has collapsed, right? There's actually a tension pneumothorax because the air is going in and it can't come out. So it's only a one-way street, right? And it starts pushing everything to the side. So that's technically a tension pneumothorax, right? So that's a drop in V, yeah. It's also a drop in Q sometimes. That's tension pneumothoraces are really a drop in Q also. But let's just do like a regular pneumothorax. So that's going to be what's kind of VQ, low or high? Be a low VQ, right? And due to a pneumothorax. And then number 5, what's number 5 right here?
Pulmonary effusion.
So pulmonary effusion versus pulmonary edema, what's the difference? So effusions are in the interstitial spaces, right? So this is an effusion. If that fluid was out here, that's a pulmonary effusion. If the fluid is in here, which it is, that's called pulmonary edema, right? And it's usually due to, like, there's a big heart here, the heart is failing, and all the fluid is backing up from the left ventricle to the left atrium, all the way back into the lungs, right? So and that then pushes itself into the alveolus because it's all the increased pressure will leak through those capillaries into the alveoli and reduce or improve my VQ, or cause a low VQ or high VQ? A low VQ, right? The ventilation is fine. There's no, I'm sorry, back it up. So the perfusion is fine, right? It has a lot of extra perfusion, actually. There's a lot of blood inside those lungs, right? But the ventilation, the amount of air that's going into that lungs, it hasn't changed, but when it gets down to the alveolus, it can't exchange O2 and CO2, right? So that's called pulmonary edema. Specifically, this is cardiogenic pulmonary edema, right? And then number 6, what is that? So it's pneumonia on steroids. Literally, you give steroids for this kind of disease process. You also get pneumonia for community-acquired pneumonia. But anyways, this is pneumonia that is exponential, right? It's not just one lung, but it's pretty much it's all of the lungs that are getting affected here. And it's a edema that's developing, but it's edema that's a little bit spicy, or I should say thick, because it has a lot of protein, a lot of pus, a lot of extra fragments, huge inflammation, inflammatory response is going haywire here. This is normal over here, and this is abnormal or pathologic, right? So this is, what disease process is this? Where all the lungs getting filled with fluid, not because of the heart. It wasn't the heart that was backing up into this and filling up with fluid. This was a pulmonary edema due to not a cardiac source, which is called non-cardiogenic pulmonary edema, or otherwise known as, yeah, this is ARDS, right? And this is everywhere through the alveoli. It's not just one little spot. When you look at CHF, usually even on the X-ray, if you look at the pattern, it fills up on the X-ray. You can kind of see that it's only kind of around the heart, around the pulmonary vascular congestion. You'll read on the X-ray. It's just kind of right there. But then it starts getting bigger and bigger and bigger with the worse off the heart failure is, right? The whole lungs get kind of filled from the center outwards. It's usually bilateral. It's going to be just one lung, right? Whereas ARDS, they call it ground glass opacities. There's literally all this stuff is all throughout all the lungs, and it appears like shattered glass all the way, otherwise known as ARDS. Okay, and obviously that's going to drop my PO2 dramatically, right? There's definitely a VQ mismatch. The O2 can't get into those capillaries great at all. Okay, and it's diffuse. It's much worse than just a regular pneumonia. Okay, so hypoxemia. So what this we've been talking about. This is called a type 1 respiratory failure technically. Type 2 is due to CO2 buildup, and we'll talk about CO2 later, but I think we have just one slide on it right now to get you introduced. But CO2 can build up and make you stop breathing, and O2 can drop and make you stop breathing too, right? Or make you, low O2 to the brain will make you stop breathing, right? So yeah, so we have respiratory failure. We stopped breathing, or our lungs didn't work good because either I got a CO2 buildup in the end, or I have an O2 drop in the end, right? And the O2 drops inside my bloodstream. That's technically hypoxemia, right? So hypoventilation, low FiO2, right? I'm not taking in oxygen. That's going to be, the O2, my ventilation goes down and down and down. That's less oxygen that's being delivered to your lungs, to your capillaries over time, right? So that's called, that's hypoventilation can definitely cause hypoxemia. And also, you're not getting O2 into your lungs, you're not getting CO2 out of your lungs. So it actually also will increase your CO2 too. All right, and then low FiO2. So 21% is room air, right? But what if I go up to like Mount Everest, or I go to a higher elevation, right? That's a decrease in the inspired oxygen, right? Or from underwater, that's a decreased inspired oxygen, right? These guys always respond to 100% oxygen. You 100% oxygen, these guys, they had no lung process. They don't have ARDS. They don't have a PE. They don't have any of these problems. All they have is a decreased inspired oxygen, right? Because either they're not ventilating or the oxygen in their atmosphere is low, right? And then, so that causes you to have hypoxemia, low PO2. And the PO2 less than what? What's a normal PO2?
80 to 100.
80 to 100, right? So less than 80 on our ABG, that's going to tell us that we have hypoxemia. Then we got to figure out, why is it? Did grandma get too many narcotics? Maybe that's what happened. Did grandma climb Mount Everest? Maybe that's what happened, right? So we got to figure out what the reason was. All right, and then VQ mismatch. So we have a shunt or a dead space, which we've been drilling for the last 4 or 5 slides, right? So then VQ mismatches can be just one little tiny spot, right? Or it can be diffuse, like what? What process is diffuse? What lung process happens in all the alveoli? COPD is a long-standing thing that can do it too, but something like a ARDS process, or a really like multifocal bilateral pneumonia can do it too, right? All right, and then something called the AA gradient. So we'll touch on AA gradients. The big A is your alveolar PO2, right? It's about 100 or so, okay? So that's how much PO2 is inside our alveolus at all times, right? And then we have our little a, that's our PO2, which is our ABG that we're used to, right? Which is what numbers again? 82, 100, right? So that's our normal PO2. So that's like a normal situation over here. We got 100, and the blood dropped off 40. You know, it dropped our tissues picked up all the oxygen that the arteries delivered, and then it dumped. Then you're down from 100 all the way down to about 40, right? So now you have 40 come into the lungs, and now it's ready to pick up oxygen, right? So 100 to 40, it's going to go all the way across by diffusion, and that's going to improve things, right? But if that doesn't happen, like in this situation here, this is a drop in my what, Q or P or V? Drop in my perfusion, right? Like a PE or something, right? That's going to cause a dead space, and that will then cause hypoxemia, okay? So AA gradient, those are that we talked about before, but to apply it, so now we have a PO2 on one side and P little AO2 on the other side. So maybe there is something in the way, right? You got something in the way that's making it difficult for my O2, the oxygen in the lower alveoli to be elevated, right? There's something there's not a lot of there's something going on. There's a diffusion restriction, like in fibrosis. There's a mucus in the way. There's something going on. Okay, so that's the difference between these things, right? And PO2 is a fancy formula that we'll kind of just touch on, but that's you can measure that and it can tell you if they have an actual like pneumonia or if they just have hypoventilation, right? Because of hypoventilation, there shouldn't be a difference between these two areas, right? If they're just breathing low or not breathing much at all. Okay, so alveolar versus arterial oxygen content, right? It's just not getting through, or it's getting through just fine. It's just the inspired oxygen, the partial pressure of inspired oxygen is low. Okay, and every disease process ever, except hypoventilation and altitude, has a rise in AA gradient. Because if I have a pneumonia here, well, that's a big difference. That's more of a difference. If I have pulmonary fibrosis here, that's more of a difference, right? So the only real usefulness of that is when you're looking to see if they got just too many narcotics or they climbed Mount Everest, right? So yeah, so hypoventilation, they got a VQ mismatch, they have a shunt of some sort. All these things are going to make it so that I don't have I am hypoxic for some reason or another. Okay, so this one over here got dead space, I got a lack of flow. This one over here, I got a shunt because there was something in the way. Bronchospasm, a emphysematous patient, like COPD patient, mucus, whatever it may be. Okay, mucus plugging, atelectasis, pulmonary edema, all these things are making it so I can't oxygenate well. Therefore, I get low oxygen in my bloodstream, which is called hypoxemia, right? And we mentioned there is, usually it's PE that causes a problem with a high VQ. Other reasons would be like really, really profound pulmonary hypertension, or if we have too much PEEP on the ventilator. That can, these alveoli get way, way too bulbous. They get too much PEEP inside of it, and it impairs blood delivery to the lungs, right? And PEEP, when you're on the ventilator, you can't say just go to the subsegmental left lower lobe, please. You can't dial that on the ventilator, right? It goes to all the lungs, right? So too much PEEP can cause a drop in our perfusion. Okay, but usually PEEP and FiO2, those are the two things that fix a low oxygen. Okay, and then what else? So pulmonary hypertension is our next topic. But yeah, so this is just a recap on our VQ mismatches and hypoxemia. So pulmonary vasoconstrictions, which leads to pulmonary hypertension, this is where you have your lungs have vasoconstricted, right? So we have a vasoconstriction going on, and that's going to reduce flow to my alveolus over here, right? So why did that happen? So it's actually a protective mechanism that your body does. It's the only place in your body where when your oxygen is low, you're going to vasoconstrict, right? When your oxygen is low in your brain's like, shoot, vasodilate. I would get more blood up there, right? When your big toe is hypoxic, right? It's going to your vessels are automatically going to go to what's called hyperemia. It's going to vasodilate. It's going to do a little local inflammatory process. It's going to vasodilate, right? It's going to cause a increase delivery of oxygen there so that your toe doesn't fall off, right? That's how your body responds, but not in the lungs. Your lungs will vasoconstrict when you have hypoxia in that part of the lung, right? If I have a huge pneumonia over here, right? So let's do it over here, right? I got a little big pneumonia over here, right? And here's my right ventricle. It's pumping, right? It's pumping blood to my lungs. It's like, and it has a choice. It could go left or it could go right, right? It only ejects about 70 to 100 cc's, right, of blood. Now, do I want all 100 cc's to go 50-50 on both sides? Or I'd rather kind of reroute traffic and say, nope, don't go down there. You don't want to go down there. They're really weird over there, right? Or no, they have pneumonia over there, right? So don't go down that way. It's vasoconstrict, right? So it does that like almost instantaneously. It can like predict the future. The chemicals that travel down this super fast to vasoconstrict is really ridiculous, right? It's crazy how it vasoconstricts and reroute blood over to the healthy alveolus, right? So it's called pulmonary vasoconstriction. It's protective. But no one predicted everybody will get COVID. Nobody predicted people will smoke these things called nicotine and cigarettes, right? Nobody predicted that people get as obese as they are nowadays, right? So all this causes obesity hypoventilation syndrome, it causes COPD, and it causes all kinds of problems that lead to chronic hypoxia, right? So you're not just chronically hypoxic to one alveolus or one segment of your lung, you're chronically hypoxic to all of your lungs, right? So that's a pulmonary vasoconstriction everywhere. Now now where does it go? This is vasoconstricted, and over on the other side is vasoconstricted as well, right? Everything is vasoconstricted now. So what's going to happen next? Well, the right ventricle is going to start getting upset. So here, right ventricle usually pumps blood to the lungs, but now if everything is vasoconstricted, now that's going to put more and more stress on the right ventricle, right? And it can even fail. That's called right-sided heart failure, right? But we don't just say right-sided heart failure, we translate it to Greek, right? Because that's what a provider or doctor does. You just tell them the problems, they say, hey, let me translate to Greek. That's cor pulmonale, right? That's what you meant to say, okay? So cor pulmonale is a right-sided heart failure due to a lung process. COPD patients get this. A obese patient will get this. A long COVID patient will get this. Someone with pulmonary fibrosis, right? All the lungs are fibrosed and scarred. They're going to be hypoxic at baseline. Yeah, the first 3 months they might not have symptoms, but they might have like exercise intolerance or something. But over time, that's going to lead to right ventricular failure, right? So these guys have to be on medications to kind of vasodilate the lungs, right? Vasodilate the lungs, you can't usually tell a medication just go to the lungs. Don't worry about the rest of the body. It's all these medications are going to vasodilate, but they're also going to cause hypotension as a side effect, right? One of the ones you might be familiar with is sildenafil, right? What's sildenafil? Viagra, right? So we gave Viagra, and it's going to vasodilate, right? It was initially, like in the late 80s, it was given as a blood pressure medication, right? Pfizer's like, hey, we got this new medication for blood pressure. We're going to save lives, right? And then the guys come in and it's like, hey, has another side effect as well, right? I have great blood pressure, but then I also have great love life as well, right? So then they market it as like, oh, that's not a side effect, that's a marketing opportunity, right? So they then changed it to erectile dysfunction drug as well, okay? But then sildenafil, it's a vasodilator. It just blocks these pathways that will end up creating more nitric oxide, and nitric oxide is a natural vasodilator, right? So it's going to vasodilate these guys with pulmonary hypertension. It's going to vasodilate the lungs, right? The lung arteries, pulmonary arteries, and help them out, right? In the acute phase, we can give nitric oxide and prostaglandins in the ICU. We're still kind of hashing out the policy on this, and to get it going live, we have all the equipment and all the medications. This is something that might be coming up in the next 3 months or so. I said this like 2 years ago too, but anyways, the next 3 months or so, it's going to hopefully fly, where you give inhaled medications that go right to the lungs and vasodilate for someone who has chronic pulmonary vasoconstriction, like your obese patient or your COPD patient. It's only there are technically 4 types of pulmonary hypertension. It's only for like type 2, but it's really for patients like this, not for someone who has heart failure, right? If you give this to someone with heart failure, it's like, oh, more room for my fluid to go, and that's going to worsen their heart failure, right? But someone who has this chronic pulmonary vasoconstriction, we can vasodilate them, help them oxygenate better. Okay, so nitric oxide, that's just pure nitric oxide. That's what sildenafil was doing in the first place, making more nitric oxide by a pathway, by like roundabout way to get more nitric oxide. But nitric oxide is just straight up nitric oxide. That's going to vasodilate locally, and that's an inhaled gas, right? There's not many inhaled gases we have in the ICU. You could do it, right? Our ventilators can do it. The GE monitors can do it, but it's really what they'd be probably doing in the OR. Okay, but inhaled prostaglandins is something we can do, right? We just attach it and we put it in the ventilator circuit, and it actually just goes right to the lungs and vasodilates nice and easy for us. All right, so yeah, so that's a hypoxia. Widespread hypoxia causes vasoconstriction, right? And yes, it's normally protective, but with chronic hypoxia, that's going to, our COPD patients, our obese patients, and our obese patients have obesity hypoventilation syndrome. That's where they are too big to breathe, where their chest wall is literally too filled with adipose that it can't expand adequately, especially when sleeping. So they are chronically hypoxic over time. Okay, so they develop pulmonary hypertension, and that leads to also right-sided heart failure, otherwise known as cor pulmonale, right? And also chronically high CO2 also vasoconstricts. So our COPD patients are more at risk for this. Okay. So yeah, so giving nitrates and calcium channel blockers, we got to be careful with these kind of patients because it can, if you vasodilate everything, right? That's cool. You're going to improve. You might improve someone's blood pressure if we're giving like a nitrate for their blood pressure, but you can also vasodilate the lung, and you can dramatically take all that CO2 that was kind of hidden away, and it can then just wash in the bloodstream. That can cause acidosis and cause vasodilation. It can also, when you have a really high CO2, it can push away the oxygen that's on the hemoglobin as well, and cause patients to arrest. Right, so we got to make sure our blood pressures are usually good before we intubate somebody for that reason as well. Okay, so pulmonary hypertension again can be treated with these systemic or inhaled pulmonary vasodilators. Okay, and then yeah, milrinone is another drug you'll see in our hemodynamics section. It's actually a great medication that dilates up our pulmonary vasculature. Okay, so that's the idea. Nitroglycerin, milrinone, nitric oxide, epoprostenol, these are all medications we can use in the ICU to help improve someone's low oxygen state due to pulmonary vasoconstriction.